And we are back with another 40 Under 40 Public Health Catalyst Award winners. We have Dr. Christin Gilmer with us here today. Thank you for being here. So Dr. Christin Gilmer is a global health lead, and she's also done public health research within COVID-19. But I definitely want to give her more of an opportunity to introduce herself a little bit more. So Dr. Gilmer, can you go into a little bit more about your current background?
Sure, I'm really happy to. And thank you so much for having me and for this incredible award. It's very humbling and exciting, especially that there's focus on the field of public health. So I'm currently working at GH Labs, and we are a nonprofit who works really in support of and in tangent with the Gates Foundation to scale up technology and resources for primary healthcare and other necessities in low and middle income countries. It's a really interesting capacity where we focus so much on innovation and really on in-ground partnerships and working in the field to make sure that people are letting us know what they care about. We have evidence and data to back it up, and we can support those needs. So it's a really interesting new model and one that we're really proud of, and I'm grateful to be a part of. And that has scaled into new work at that organization in implementation science and monitoring, evaluation, and learning, which we're now kind of phasing into. So I love doing that. I'm also a person who leads our public health and COVID-19 research team at MEDAN. We do a ton of work with journalists, nonprofits, and lots of groups around the world, especially ranging from local driven news media to huge groups like Reuters, New York Times. We just have a lot of people we get to work with on public health information and combating misinformation. So as you can imagine, the last couple of years have been pretty wild, but we have an absolutely incredible team of technologists, of public health experts, of journalists, of strategy designers, and people who encompass this really interesting intersection of both technology, journalism, with the added benefit now of public health. So it's really, really fun, and we get to have a front row seat to combating the information we see that comes up, but also disseminating information that is culturally and locally contextualized for the people who are receiving it. So if language is an issue, if metrics are an issue, if some kind of translational aspect of that doesn't necessarily equate or really resonate with the people who are learning from it, we have a localization lab who really fits our big picture and our words and our data into the minds of the people who are receiving it, and hopefully ways that they can reach. So that's things like WhatsApp, Instagram, TikTok, streaming platforms, and then looking at new ways to really, I think, highlight and disseminate more information to the people who need it. Lastly, one of the things I'm focused on the most is I work a lot with the Special Olympics on inclusive health, and through a program called Healthy Athletes. We recently just had the USA Games in Florida, which was incredible, and relied so heavily on the partnership of the USA Games staff, Special Olympics Florida, Special Olympics International in North America, and thousands and thousands of volunteers who came to provide thousands of medical screenings and lots of health education and promotion to our athletes who have intellectual and developmental disabilities. And that's such an absolutely incredible program. It's a framework and a style and strategy I really try to emphasize in my own personal work and in my consulting and lots of pro bono work, because it is holistically focused on access to care and making sure that we have equitable outcomes, that we make things as inclusive proactively as possible as opposed to reactively, which is probably a pretty good metaphor for our health system at this point. But those are really the three major roles that I take on for myself. And I think they all just sit at that little pinpoint of health equity and access to care, trying to lower those barriers and making sure that inclusive health is something that involves every community, every person who is a member of the healthcare system, which should be every person on earth. It's an interesting set of roles, but ones I'm extremely passionate about and so lucky to be a part of.
Wow, that was just very poignant, and I love the different things that you're involved in. From the different types of, as you said, like the locally and culturally relevant and contextualized research, to helping with the Special Olympics and some of the health needs. I wanted to dive a little bit deeper. So if you could give the audience one example of a piece of research that you've been a part of that you found the most intriguing or the contradictory or something that just was unexpected.
I mean, we see this a lot. One of the biggest opportunities to learn that we've had, it comes from COVID and what a lot of our early disease modeling showed versus what we actually implemented plan-wise. So some of the research that surprised me were the communities that were hit hardest and the communities that were not impacted in the same ways. A lot of this is a nice reversal of the high income healthcare system kind of dictating to other societies how they should run their systems, when in fact there are many countries I normally work on, especially with epidemics like Ebola or malaria or cholera, who said, no, 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 stay there. You guys have COVID. We're okay over here. We've got protocols in place. And so it's been a really interesting kind of slice of humble pie, to say, yes, you study disease, you work with these local communities, but your own health system hasn't really responded to this in a way that would generate a lot of confidence in you being able to do that in other countries. And so for me, some of that has been on high income people who may have access to care, maybe fair skinned, maybe highly educated, but are still having very severe health outcomes when it comes to things like COVID, which you don't normally see. And in other countries, we haven't seen nearly as much of. So for me, that's been a really surprising and humbling piece of information. I'm one of the people who, when the pandemic really kind of started coming into fruition in terms of the data and the evidence base we saw, did not assume it would scale up as quickly as it did based on the virus itself and its fitness and what the epidemiology behind that looked like. So I think that was probably one that shocked me. But every day, if you're working in global health, you're going to see, oh, excuse me, you're going to see data that is shocking and jarring in a way that hopefully moves you to act as opposed to just upsetting you. So I think that's the key difference between what I do and what I could do, which is wanting to make changes based on those things you learn versus saying, this is really frustrating. I'm upset about it. And it's nice. It's nice to have the opportunity to have action. I think that's what most people want, actionable chances once they learn something new to impact that change. And how lucky am I to have the background I do and the people I get to work with who actually let you do that, let you try these things out with the people who are receiving care and providing care. It's pretty wonderful.
Right, I couldn't agree more. Like that actionable piece to one's life, and yeah, I agree. Wanting people in our audience to be able to see things within public health, to see those challenges, that disturbing and jarring data, whatever it may be, those
Right.
those issues within social justice, and not to just get up, frustrated and blow up, but to be actually able to do something about it in whatever capacity they can, given their own talents, their own expertise, and their own capacity at any given time. But I wanted to actually go back. We did not get a chance to talk about where are you calling in from? What part of the world are you in?
So I'm calling in from Seattle, Washington.
Okay, excellent. And tell us a little bit about your public health journey. So we've talked about all a lot of different areas that you're working with now, but how did you get to be where you are?
That's a great question. And one of the best pieces of advice I got about this, and this is for anyone who's young or maybe interested in public health, is it's from Cecile Richards from Planned Parenthood. And she said in this very small session we had, my resume doesn't make sense if you look at it chronologically, but if you go backwards, every step is there. And I suddenly got it, and just thinking, oh, because sometimes you'll want to jump from something you're passionate about to the next thing and to the next thing. And the linkages may not be super strong, but it makes sense in the long run. And I think mine is a journey like that. And it just made me feel heard and maybe fight some imposter syndrome a little bit. But I'm from Arizona, and I apologize. We keep having lights flicker, so I'm very sorry. I'm from Arizona, and I grew up in a small border community called Yuma. My family is from rural Mississippi along the Mississippi Delta, and we are not really a town that you would call super progressive in terms of education or health systems or anything like that. But I was extremely lucky because I was surrounded by such devoted people, especially teachers, especially people providing care, people who just really were focused on community and localizing what they do for to be really tailored for the people who receive that. And I mean everything from seasonal farm workers and agricultural workers to cashiers at local grocery stores to librarians who always know everything about everything. It's one of my first sources when I do research in any country is say if they have a library. But for me, I think growing up and seeing the disparities between people who were either citizens of this country, or people who were migrating back and forth, people who came from other countries, people who were indigenous because we were on tribal land. Arizona, as you know, has a huge percentage. It's not huge. Arizona has a percentage of land that is established for Native American indigenous populations. It, it should be the whole state. It was for a very long time. And seeing the differences in care people got and the differences to access people received was really jarring. So I have a health disability and something that's called an ultra rare disease, which is not a scary one. It's not fatal, nothing bad. But I had a lot of odd health issues growing up. I had profound hearing loss, super weak teeth, sometimes kidney pain or spinal pain, and dislocated a lot of my joints. And some of these are so early I don't remember them. But anytime I had an issue like that, because my mother was a teacher, I was able to go to the doctor and seek care. And so many of my classmates outside the nurse's office didn't have the same opportunity unless they were people like Dr. Ernie Rios, who is from, he actually was a sports director at my high school, unless he provided free physicals. A lot of times people just wouldn't have the access to that based on income, based on color of their skin, based on their population of origin, the places they come from. And I remember thinking there was something inherently unjust about that. And it happened a lot. I was a person who was often the only fair skinned person in the room, often the only English speaker. And I was lucky to be in classes where we only spoke Spanish and eventually moved to classes where you spoke English. But I felt like people were so accepting of me into their culture in places where my family hadn't been from. They're from Mississippi. And yet, the systems that were established to really care for the people of that town were maybe not as just as they could be. Not to say there wasn't a want to do so. Tons of teachers and care professionals went above and beyond to do everything they could to ensure people within the community, especially kids, had the greatest level of access to care, education, socializing, group support as possible. But that was a theme that kind of resonated with me. And I think it's a sense of injustice that there's a lot in the world that is frustrating, and there are many different approaches you can take to combating that. For some people, that's something like becoming a teacher and impacting dramatically the lives of 30 to 40 kids a year, depending on what state you're in. For some people, that's the military. For some people, that's being a musician and keeping traditions alive of your oral and cultural history. For me, it really resonated when I was 16, and I started reading these articles and listening to people like Bono talk about how HIV was going to take out one third of Africa if antiretrovirals weren't scaled up and distributed. And it wasn't that aspect that was shocking, because of course that will happen with any infectious disease if it has a high fatality rate. But this one doesn't need to. It never did. There's ways to care for it to make it a chronic illness versus just an infectious one. The problem was that there was a debt burden that so many of these countries faced. So as opposed to spending whatever percentage of each dollar, and we'll say dollar just as a common metric here, on antiretrovirals, preventive care, testing, lots, basically anything you can imagine within the continuum of care, they're spending it paying back countries for centuries old loans that their grandfathers made in eras like colonization and in ways that were just completely unjust. And so seeing these systems and just thinking how things from hundreds of years ago still impact the health of people today in extremely preventable ways, I just felt really motivated to do something, but also it kept hitting me, it kept hitting home for me that the care that I had, because I went to college in Arizona, because I had a parent who was a teacher, was so much different than the care of my friends and family in Arizona, Mississippi, who may not have had those same resources. it just hit home for me in so many different ways because it was the intersection of everything I love about public health. It was policy, it was politics, it was social justice, it was history, it was community, it was evidence and data. And all of it kind of came into this amalgamation of this massive HIV crisis, which the US has a very large role in perpetuating, delaying, and responding to treatment wise. And so from that point on, I really dove into that and became a person who worked with that AIDS Trade Africa, started working with a lot of AIDS organizations, AIDS service organizations around Arizona, Los Angeles, some in New York, and really started teaching classes and kind of scaling up. And at the time, I was also working in things like music and TV, thinking, oh, I have a great interest in this. This is exciting. But really knowing my heart was never there. It's always kind of been in health as the foundation for equality. And since then, I started working, I think it's smaller HIV orgs, and then kind of started my own nonprofit in Arizona that tried to connect people to care regardless of their background. And from that point on, I kept working in local politics. My real background's as a community organizer. I think that's where the HIV work and the activism work really came into fruition. And I worked full time as I got into grad school, and it was just a really humbling experience because it was such a learning opportunity from so many people who saw the same injustices and wanted to better them. For a lot of people, it was just improving care. But for me, I think I saw public health, and still do, as the opportunity to undo inequities. It's the most incredible opportunity in the world. You can really, we talk all the time about DEI, and we talk all the time about equality. But if you can help people, if we're talking Maslow's hierarchy, which I know has been discredited by a lot of people, but if you can meet people on that first level, provide housing and safety and not exposure to environmental toxins or bombs or the threat of being invaded, if you can give people a basic foundation of health, preventative medicine, and the ability to access education, then equality is a much easier goal to achieve. Granted, it looks different for every person than if you're just consistently responding to gaps. It's also interesting because to me, inequity is a process, or excuse me, equity is a process. It's not just a destination, it's a consistent, constant focus on how to improve access to healthcare, but also we know our history is pretty brutal. We know that our care system hasn't been designed for everybody, but so many incredible people, especially Black and Brown people who've been shouting this for hundreds of years, we're really learning how to tailor and create systems that make sense for everyone and are inviting to everyone, make them want to participate. You can't just go to a doctor's appointment and assume it's the same for a multimillionaire in Medina, which is just across the water from me in Seattle, as it is for a person from the Quechan tribe from where I'm from who accesses their care through Indian Health Services, or someone in rural Kansas who may have health conditions they're never aware of. It looks different for everybody. And so for me, my journey in public health has really been focusing on the misnomer of a culture of health as opposed to cultures of health, and really learning what that looks like for people, how to listen to those communities directly and be a platform that helps people really uncover those opportunities, see how we can improve care, and let people achieve the health outcomes they want, because that's different for every person, every single person. And I think it's very difficult to do within a health system, but we have enough evidence and such a plethora of data that now we know exactly some steps we can take to start getting more equitable outcomes and approaching populations in ways that work for them, with their local groups telling us what they want as opposed to the other way around. A very long story. I apologize. It's got a lot of twists and turns, but I think there is a stream there of making sure people recognize you cannot achieve equality unless you're constantly striving for equity.
Wow, I absolutely love that. There were so many wonderful quotes, that I just kind of snipped, from what you were saying. Equity as this continuous process, and just your focus on things being more comprehensive and holistic, as opposed to, as you said, just responding to gap after gap after gap. And then
Right.
also the piece that was really resonant with me was also like the health that people want, right? And how that looks different for each person. And as you said, the cultures of health. And absolutely, as you were talking about, going into a doctor's office for one person in say one country versus in another country. I was thinking even within, this country of the United
Oh,
States,
yeah.
how different it can be. Same provider, right? The one patient who walks in to see that provider, and then the very next patient who might walk in another 20, 30 minutes later, and that actually might be quite different. And that also is an issue of equity.
And the journey just to get there. There was American Medical Association had a broadcast about a year ago. I'm gonna actually try to look up the person who said this because I want to make sure I get it right. But she talked about the journey to the doctor's appointment for each person. And I thought it was fascinating because she mentioned that one person who might take a journey to their female health appointment will likely have a higher likelihood of getting stopped and frisked along the way, getting yelled at, having to take several bus connections, versus one person who might be getting there in a Prius from 2003 that their brother gave them, versus another who has an easy and safe walk where they're not going to face the same types of hazards or the same motivation to go there. If you're surrounded by flowers and trees in a park going to a doctor's appointment, you're much more likely to want to go there as opposed to a 17th story building with no elevator or AC that's in a highly polluted area surrounded by lots of junk food because an intentional food desert has been surrounding the area. So all of that I think is a really different journey and teaches us a lot about the social determinants of health in just one single walk. And it's pretty profound to think about it in that capacity because I don't think it's something most of us have to consider when we talk about care. In fact, for my disease, had my exome not been sequenced, we wouldn't know. there's there's no way. How many people in the world have either the financial, social, occupational, or economic background that I have as to where they can say something's wrong. We've taken some tests, we have to figure this out. It's not adding up. So few. And so how many diseases, we call them neglected tropical diseases or ultra rare diseases or chronic conditions that are historically underdiagnosed are actually extremely common. We just lack the access to diagnostics and tools and cares because of health systems and how they're structured to really scale that up. And it's actually one of the things I love about my job at GH Labs is that we're really trying to fight that and make these equitable tools accessible to people in every rung of the population, but especially in primary healthcare, your first point of contact within the health system. That might be a community health worker at a last mile post. That might be someone at a regional teaching facility outside Makerere University in Uganda. I don't know, it's different. But I think these lessons and what we hear from people in those zones are what really should determine exactly how their care is given and what that looks like. And at Special Olympics, that's one of my favorite things because the foundation of care is for this population who is historically marginalized in so many ways. It varies so much depending on the athlete, their national healthcare system, their personal issues or conditions they may deal with, and their sport. And so it's really fascinating to see people who may not be aware that they have any issues and get cancer diagnosed or see or hear for the first time because of the tools they access. But I think some of the real breakthroughs are saying, wow, this person's never had a bone density scan, or their blood pressure is very high, which is a pretty common thing within this population. Wow, how can that data set influence how we start treating people earlier in their life? And in this whole spectrum of care, how can that influence the policies that make this an inclusive health system? So there's so many steps along the way, but now we know from framework and discussions by people who are much smarter than me and have many more research hours for decades telling us, hey, this has been proven, this works in this community. It may be something you can customize for your own. It's an exciting opportunity. And I think something that we really have to take to heart. And a lot of that is uncomfortable and admitting faults and shortcomings. But I don't know any clinician or public health person who's not willing to undergo that discomfort for the sake of billions of people around the world who could benefit from having more just, more equitable systems.
Another point I couldn't agree more. And there were so many things, in what you just said. The one thing I wanted to tease out, you were talking about neglected tropical diseases, but I wanted to think about things that tend to be invisible. And for you, Dr. Gilmer, what are some things that tend to be invisible or not as highly discussed in the public health discourse that you know of that you would want our audience to be more mindful of?
That's such a great question. The first thing I think of is disabilities, because when we're talking about inclusive health, I think it's a lot easier to frame on the majority as opposed to the minority. But the minority is such an odd definition here, because we estimate that 15 to 20% of the population in general has disabilities. If you add in chronic illnesses, it's closer to 40 or 50, which is roughly half the population. You're getting to majority status here. But when it's things like mental health that aren't as sexy, that aren't as glamorous, it's a lot easier to say, yes, I'll be there for you. But when that friend calls you for the 10th time in 10 days, crying, saying the same thing that they did the night before, are we really equipped to handle that as society? Do we know what that looks like, what that support looks like? There's a lot of communities in places like South America or Sub-Saharan Africa that have really beautiful models built around that. And I'm not necessarily sure that's something, as an American society, we are really well tailored to handle this kind of community model of care and making sure there's support built in every way, especially socially. It can be really, really difficult, but I think the key is cultures of health look different for each person in each community, in each condition, frankly, and for each provider. But some of the key issues really resonate across the board, and it's things that we have to consider from ideation into implementation. And there's a lot that we still have to learn, absolutely, but I'm glad you mentioned neglected tropical diseases. Some of them are hugely important. Chagas disease has potentially a 30% fatality rate, but it's not often tested or treated for. There was a great article that came out today that said there's really two pathways to treatment. If you treat it early, it's not a big deal, but it's something we don't even look out for. So the difficult part of this, I think, is recognizing what we don't know, which is a lot, but there are experts in the field who've been doing this forever. And then looking at things that we consider outcomes focused on marginalized population or the smaller population, when actually those may be the people who need the greatest access to care or have the best model of care because it's built in for their community. I'm going to mention Special Olympics again because they're excellent advocates. Their policy and advocacy work they do gets them attention, gets them agreements, partnerships with the CDC so they can provide this crucial data to influence those policies. So I think there's a lot of illnesses that we think have gone away that certainly haven't. I'm really scared about the disruption in services for things like HIV, for especially testing capacity, things that are chronic, that are preventable diseases, which I'm guessing is a larger part of pandemic death toll than we recognize. And I think a lot of it comes down to the really scary disease X, which we don't know is coming because of climate change. People are already pretty burned out from this pandemic. It's not how viruses work. You don't really get to tell it you're done with it. It lets us know. But there are concrete steps we can take to slow that down and to make sure people have as healthy and productive lives as possible within a framework that keeps them safe. And so when I think about the potential for disease X, isn't this a great starting point and a great way to prepare for the next pandemic from an equitable lens, knowing there will likely be something that's zoonotically transmitted, that some countries have greater capacities to respond than others? I see a lot of African countries, and especially through the African Union, who are starting to set up national pandemic preparedness groups and research sites, and everything from surgery and cardiac capacity to pathogen tracing and looking at different outbreaks. So this, I know I didn't answer your question. This is probably a constant theme with me. There's a lot of stuff I think to look out for, but in terms of diseases we're not thinking enough about, some of them are things we hear but don't feel are super actionable, like mental health, even though they very much are. And destigmatizing these issues is really going to be what changes this from a mental illness to another chronic condition. They're, of course, the same thing, but I think you see what I'm getting at. And then the second thing is the diseases that continue to plague society or will, and how we respond to them. COVID has been great in one way and absolutely terrible in terms of human loss and burnout and what it's done to us socially and culturally. The great thing is it has laid bare our shortcomings. And in that, I think it's full of opportunity, it's full of potential to reshape a system, a health system, prioritizing the things that we know are important medically and public health wise, but also now culturally, socially, and community wise. So I'm hopeful that we can take those lessons. I'm not sure we can, but some communities have already responded, doing brilliant work and having advisory boards. In fact, India, with their national healthcare system, have people who sit in on community advisory boards and respond to their local primary healthcare clinic. Those are great ideas. So I think we should listen to the people who've been doing them for a long time, especially now with Roe v. Wade being overturned. The best advice I got when I asked, okay, I think I'm going to go to DC day after I'm ready to protest. One of my girlfriends is, she's a woman of color, and she's been running an international reproductive health and sexual justice org for a very long time. And she said, oh no, what I need you to do is get data on paper and start getting it to these people. And I said, sure, I'll take that policy work and do it. She's been doing this for decades, for generations. She knows best. It's a misnomer and egotistical on my end to assume I do. So I was extremely happy to take that directive. And I think we should all, people, especially people much smarter than myself, should be able to look at these current situations and take those lenses, take those leads. How can I best serve? It doesn't mean it's the most glamorous way, but it's absolutely the way that will benefit your health system the most and the people who we are constantly and historically marginalizing through healthcare. So let's focus on that. Let's take this opportunity and focus on those smaller diseases or oncoming diseases, but really focus on the cultural and social context that are going to and should be shaping our system now.
And one of the things, and looking at your background and that you talk about, Dr. Gilmer, is traveling to a lot of different countries. And so I know we've talked
Right.
about, neglected tropical diseases, things that are visible but yet underappreciated. Could you talk about, and traveling to different countries, what are some of the things, public health issues that you've seen that you really would like to kind of put front and center for the audience who might not necessarily know much about them, but you do based on your experience?
Well, that's a great question. And first of all, how incredibly lucky am I that I get to go to dozens of countries through ministries of health or through nonprofits or doing research work to kind of help support the health teams there. And I say that because I'm not running anything. Even if on a grant I'm a PI or in a project the ministry asked me to come in and supervise or evaluate something. No way. People are experts in their field and they are telling us exactly what needs to happen or what shortcomings they feel are occurring at what level. And it's almost like you get to help problem solve from a very outside perspective. You can do all the research in the world, but you are never a member of that community. And it's only through the sheer grace of people and the kindness and the desire to treat their community with the utmost health standards possible that I get to go. So I recognize that. And I also recognize I'm a very fair skinned, tall person from the US. I am not born in those countries, I am not from there. And I think that's a really important part of recognizing it and historically what the approach of the white savior idea has done to global health. So knowing that, it really does change the approach of what health justice looks like for me in those countries because it's tailored specifically to the goals people have. The things that stand out the most for me are social determinants of health because we know we have enough food to feed the planet. But if you go to places like Yemen, if you go to the Horn of Africa, if you go to right now Ethiopia, there is such a hunger crisis you likely won't read about on any front page news, but parents are having to watch their children die. And it's jarring and shocking and completely unjustifiable by any means outside maybe people thinking about capitalism. But there are places and situations and organizations and even very wealthy leaders who are working hard to combat those types of systems. But it has to do with supply chain, it has to do with equality. I ate something I bought at Whole Foods the other day, which was grown in Mexico and packaged in, I believe it was Brussels. And I just thought, well, I'm in Seattle, so that's interesting. It's not something I'm going to see when I'm in Lesotho or Botswana. So I think the access and distribution channels are really, really important there. Of course, social determinants when it comes to environmental exposures like indoor cooking stoves or pollution, but especially food are huge issues. And to this day, two of the things that I really, when I'm working with ministries or when I'm working with international nonprofits who work directly with governments, that I look for is access to women's reproductive health care and girls' education. Those are two of the things that really stand out where if we think a country is going to do really well or whether a pandemic or develop a health system that's truly more equitable and inclusive than there currently is, it's usually involving those two components. So it may be a gender equity lens and somewhere along the gender spectrum that can come into fruition. But yeah, it's surprising. And then there's things you always see outside of really surprising outbreaks, which of course, luckily we don't see often in the United States. But there's going to consistently be things like cholera. There's going to be dysentery. Any place you don't have latrines or potable water sources or really great sanitation practices or wash and hygiene issues, you're going to keep seeing those issues as the climate warms and we see more pathogens spread and microbes proliferating everywhere. Those are going to keep happening. So a lot of it isn't surprising. A lot of it's what we expect. And then you add in the potential for something like disease X, and the trajectory for those expanding becomes exponential as opposed to something you can prevent. So I think it's a mix. But with that being said, a lot of the populations I get to work with are extremely healthy. They're super active. They eat organic food that is farmed or they get at local markets. They have great communities. They focus on having neighborhood dinners each night. They have multi-generational housing, which is funny because it goes against our COVID guidelines, where we talk about drinking gallons or staying feet away when we have multiple generations living in one house. So something like isolating isn't possible. It just shows you how things are really dictated for one population and not another. But you see often much healthier people. And I have to say, there was a place in South Africa I worked. I'm a huge fan of the country because the women and the men who work there and the people in general are extremely devoted to care in their communities. But I see mothers hike 30 kilometers with babies on their backs to get vaccines. And at some point, the rate of vaccination was lower in places like Beverly Hills and South Sudan. And you see people do everything they can to access that care because we have evidence that shows this, and their trusted local leaders tell them it's what to do. And they've had less infant mortality and less maternal mortality because of things like that. And so I see a lot of health behaviors we need to be mimicking and a lot of focus on groups and the holistic healthcare system, shuttles and food services, and making sure if people are coming by to get antiretrovirals, they either have a way to hide it or they have an incentive to come. Is that money? Is that giving someone a break with rent? Something like that. Because if you're going to be taking a pill consistently that makes you feel ill, it might help to have some other benefits along the way. So I think we have a lot to learn from those countries, frankly. The health outcomes are often different, but in terms of things like COVID, look at Rwanda. We have so much we can learn from them and should. But sometimes I think we have to remove ourselves from the situation and what COVID has really laid raw for all of us to see and start implementing some of those changes.
Very, very powerful juxtaposition. You had, just talking about the woman hiking, I think you said 30 kilometers
30 kilometers.
and the outcomes versus, how it would be in a certain community here. Very, very
Yeah.
striking. I wanted to switch gears just again, and if we could talk about at least one inspiring moment in your life and or career and one challenging moment that our audience might be able to relate to in their own life.
That's a really great question. I think I get inspiring moments every day because we get to see what a cool place in history we're in because we get to see the impact of evidence and policy on actual human beings. And a lawyer recently told me you have to think of every law as the potential to cause the death penalty in one person. If it's parking tickets, that could lead to five parking tickets leading to an arrest, leading to a lethal encounter, or staying in prison for a long time, especially if mental illness or poverty is involved. And I think we have to look at health policy the same way. The best, most well-intentioned policies can lead to the worst health outcomes for people if they're exclusionary in any capacity. And so it's really, really wonderful to start seeing the way people define care on a more individual basis, like the CDC and WHO potentially expanding the definition of gender. I would be much more comfortable going to a doctor who didn't dead name me or saying what my actual name is than one who wouldn't look me in the eye or recognize my desire to transition. So I think things like that are exciting. And again, because I'm on a high coming from Special Olympics USA Games, it's extraordinarily powerful to see the ability and resilience of a community to unite and advocate for the care they need and have people respond to it who are just the most good-hearted, caring people, giving hundreds of hours, if they can, over a few weeks, to really create a foundational change in the lives of others. We see this all the time, and it's a great time for public health practitioners, but also students or people interested in the field to jump in, because this is the perfect time. Equity is in the forefront of these discussions. It's never been that way before for at least the dominant communities. For others, and by dominant, I mean in terms of media and the journals, the number of times equity has appeared in the last 10 years is something like 200 times compared to what it was before. Other communities who've been facing this forever have been shouting it from the rooftops, and I hope that they finally feel more seen and validated, even if it's people who appear like me talking about some of the same examples. But I intend to learn from those people, use their lessons, and talk about their lessons, making sure they are the ones leading their communities than people like me. And I think one of the most challenging aspects I've seen is just extremely preventable losses. We see this in every single health system, and it's not just through things like vaccines. It's through poor childhood nutrition. It's through roadside injuries in places where they have to choose between paving roads or digging a community well, which it's always going to be the well most of the time. And I think we are at a place where that's not the case. Resources for ministries and our government are finite, but through public-private partnerships, through NGOs, through volunteers, that's not necessarily the case. I've had a lot of really challenging circumstances where I've seen tragedy and held dying children, and there are things I don't want others to have to experience, and I don't want to scare anybody off of public health because it's an incredible field. It's unlike anything else out there in terms of it combining all of these really incredible forces for the ultimate good, which is to help people live longer, healthier lives, or obtain some freedom, some joy in their own bodies. But it can be challenging, and part of that journey is facing those challenges, recognizing the discomfort, and finding the best way to use your skill set to help. Because what are we here for if that's not what we're doing? You know, we have this really amazing capacity to shift dialogues, to shift perceptions, and to change our health system so that those preventable deaths aren't ones that we have to see. And we can make sure policies are dictated by and for people who need them in every capacity, be that children, be that 110-year-olds in Japan. No idea. But I think we have to make sure we're building around every possibility and every person and making it as accepting and accessible as possible.
Absolutely. And I wanted to end with a final question or questions about you are one of the 40 under 40 Public Health Catalyst Award winners with Boston Congress of Public Health, the inaugural cohort. And from your vantage point, what are things that the cohort can do that you envision the cohort can take advantage of? And how do you see this group, this award evolving in the future?
Well, first, what an honor. I, I'm just super lucky because I get to work in these fields I'm passionate about. I had incredible opportunities to go to schools and learn from some of the most brilliant classmates and professors that exist. And I take such gratitude from those experiences because we've all learned ways that we can shape and impact those around us. And when you're around people who want to make the world a better place, you're going to tend to be pretty happy about those things. For me, this cohort is incredible. When I was reading some of the people on the list, I was kind of getting goosebumps thinking, do you know who this person is? I read about this person. How crazy to be on the same list as them. Um, I think I think the impact of this cohort will be everything from ministers of health to the people running large nonprofits to the people who are on the ground, knocking on doors, doing health promotion every day. But I think we have a lot of opportunities where we can engage in way more partnerships, way more stakeholder development with each other because our goals all align. At the end of the day, we are public health practitioners, we are medical practitioners, we are people who get to take really, really big ideas, tailor them and customize them for the populations we work in, and try to achieve the most equitable, positive, effective health outcomes possible. So that could be things like a hackathon. That could be things like having open sessions where we discuss what we're passionate about, what we want to work on, how we want to help. One of the greatest opportunities I've had through places like Harvard or Columbia or Oxford is getting to participate in discussions with people who are extremely passionate. Because not only are you driven by their motivation, I'm a person who's motivated mostly by passion and compassion, you get to help participate. And sometimes taking your what you may think is a really weird skill set, like defining an answer in 20 words for Reuters, and help populations that you know so little about, but other people do. And I think the opportunities for improvement are amazing, and I can't wait to learn from a lot of people in there. So I see everything from like panels to having things like American Public Health Association having a meeting and getting to talk to everyone, really talking about our common goals and how we can work to make that happen. So I'm excited. I feel like the journey is just starting. And as we kind of get to interact with these amazing people, figure out ways we can support each other, because I know for many of them, I feel like I'm their fan club president and I want to jump in and do whatever I can to help, even if that's a literature review, if that's getting signatures to get on a ballot, if that is making public speeches or helping raise money, I'm happy to do so. And I think the future of this is going to be really incredible, almost like a cohort of graduates. For my program, the DRPH, we have a national coalition and we have big WhatsApp groups where we talk about what we need and how to help. And hey, I'm looking for an evaluation framework about policies related to endemic diseases and tropical climates. Someone will know it. And so what an incredible resource, but also what a great way to connect people. I found was really true in COVID, where I connected former coworkers who run things like satellite businesses to people in Ukraine who needed some more data to help support a health station outposts. So the possibilities are really limitless, but I'm excited to build on this cohort of people and to help in whichever ways I can. What a beautiful, really humbling opportunity, and to get to participate in things that maybe outside of your scope of knowledge, but a really great way to learn and a really great way to show communities that you're showing up for them, that you recognize they're our neighbors. Everything from unhoused people to people facing addiction issues to people suffering with illnesses that have yet to be diagnosed. If we can show up for them and do as much as we can to make the most effective health system possible, what a great opportunity. So I'm just really thankful to this group as well as the people who are busting their butts in this cohort, but also in public health in general. It's been a rough few years, but I've never been as motivated as I am now to keep doing this work and to keep fighting for inclusive, equitable health for everyone.
That's amazing, and yeah, we are so excited, Dr. Gilmer, to help you and the other 40 under 40. We can conclude this interview now, and so for those in
Sure.
the audience, please go to bcph.org, 40 under 40, to see more about Dr. Christin Gilmer, as well as the other awardees as well. If you want to learn about anything and everything public health, please visit us at HPHR Journal, hphr.org, and make sure that you subscribe to see more interviews with the 40 under 40. Once again, thank you so much, Dr. Gilmer.
Thank you so much. I really, really appreciate it and all of the work that you're doing for public health and the populations we serve.
All right.